So we have seen the Miller's chemico-parasitic theory. It is a blend of two theories, two of the earlier theories, that is the chemical theory and the parasitic theory. So Miller, according to Miller, he has assigned significance to three factors, that is the oral microorganisms causing production of acid, then the microorganisms, carbohydrate substrate, and the acids itself. So we are going to study each of them in detail. So what is the role of carbohydrates? So carbohydrates which are responsible for causing caries are usually dietary in origin. Yeah, the teeth are bathed in saliva. Saliva also has, salivary composition has both organic and inorganic components. The salivary carbohydrates are also present, but they are not responsible for causing caries because the salivary carbohydrates, they are bound to proteins, they are not freely available. Whereas the dietary carbohydrates, they are freely available for degradation, they are broken down into other products, and so they are localized on the tooth surfaces, they are responsible for causing caries. The dietary carbohydrates, the karyogenicity of the carbohydrates depends upon the frequency of ingestion of diet. I mean, how many times the carbohydrate intake, what is the carbohydrate intake. Then the physical form of the carbohydrate, like polysaccharides, monosaccharides, like simple starches or complex starches. Polysaccharides, they are not easily fermentable. Then the chemical composition of the diet. Then the routes of administration, how is the carbohydrate being taken. If suppose it is taken through oral cavity, then there are higher chances of retention of carbohydrate or food on the surfaces of teeth. Suppose if glucose, for example, glucose is taken orally and intravenously. Oral glucose is more responsible for causing caries than taken intravenously, because intravenously it is not available for degradation in the oral cavity, right? So whatever amount of glucose which is fed through stomach tube or intravenously, it doesn't cause caries. Yeah, sticky solid carbohydrates are more karyogenic in nature. Suppose the carbohydrates are like in detergent food or in plant food which are rich in like fibrous in origin, they don't cause much of the caries. But sticky foods, they are retentive on the surface of the teeth and cause caries. And refined pure carbohydrates are more karyogenic than the crude carbohydrates. The crude carbohydrates are nothing but the plant in origin, they are fibrous. Suppose the carbohydrates, some of the carbohydrates, they are rapidly cleared from oral cavity by saliva. They are also less capable of causing caries. So the carbohydrate, I mean the total mechanism by which acid is produced is through the degradation of carbohydrates and the localization of acids on the carbohydrates. So bacteria, sugar and teeth, three of these combine and lead to acid production. This acid production is responsible for dissolution of the mineral component of the tooth, thereby causing caries. Suppose the carbohydrates, as already discussed, if they are fed through intravenous route, there is no chance of caries at all. Miller has also conducted experiments by incubating bread, sugar and saliva for about 24 hours. Then in about 48 hours, enough acid was produced to decalcify the enamel of the teeth. Instead of bread and sugar, if meat or other meat and fat were used, there was no dissolution of enamel seen. So meat and fat are not that karyogenic. Then the second important factor according to Miller is the microorganisms, Miller demonstrated the presence of few cocci in the dentinal tubules and a few other forms of bacteria which he named as leptothrix. So there are different type of microorganisms seen on different types. I mean, like if we consider the teeth surface, pit and fissures will be present, smooth surface caries is there, pit and fissure caries is there, and root surface caries is there. Each of these is inhabited by different microorganisms. Like the pit and fissure caries, they show inhabitants by the Streptococci mutans, sanguis, salivarius, or the lactobacillus and the actinomyces species. Whereas the smooth surface, they show inhabitants by the Streptococci mutans species and the salivarius species. Root surfaces are predominantly inhabited by the actinomyces species. It is because of their environment in which the microorganisms grow. Like root surface, it gives an anaerobic environment. So actinobacillus are more favorable for growth in the root surfaces. And according to Miller, just a single microorganism is not responsible for causing caries. There are a complex or a variety of microorganisms in combination, they produce this caries. Okay, so let us study the microorganisms in detail. So Streptococci mutans species. Streptococci mutans species, it's like it is the first isolated organism from the dental caries. It was isolated by Clark in 1924. It is a catalase negative microorganism with gram-positive cocci filamentous organisms. So the Streptococci, the basis of Streptococci, the most important substrate which favors the growth or which is metabolized by Streptococci is the sucrose. So wherever sucrose intake is there, carbohydrate sucrose intake is there, the Streptococci mutants are more will be seen more in number because they are responsible for metabolizing this sucrose. The sucrose is metabolized by Streptococci mutans in two ways. First is like they inhibit the oxidative phosphorylation of the sucrose. They break down the sucrose to form adhesive extracellular polymers. The second form is like the sucrose is broken down into free glucose and fructose by the invertase enzyme. So these two ways the sucrose is metabolized. Yeah. This conversion of sucrose to adhesive extracellular polymers, it results in formation of two substrates like glucose and fructose. Further, these glucose and fructose moieties undergo polymerization to form dextrans and mutans. So the homophospholipers of glucans are nothing but the dextrans and mutans. This dextran is like it forms a homopolymer which is like insoluble in the plaque matrix. It is like more retentive. Whereas mutan is a constituent of plaque which is less soluble and is resistant to acid attack. Fructans are highly soluble and these are degraded by the oral bacteria. So Streptococci mutans is involved in the formation of these homopolymers which in turn favor the growth of bacteria. Then lactobacillus. Lactobacillus is a gram-positive non-spore forming bacteria. They represent about 1% of oral flora. Lactobacillus, it is both acidogenic as well as acidic bacteria, and they inhibit the growth of other bacteria because it has both acidogenic and acidic properties. The medium used for growth of this lactobacillus is the selective rugosa medium. Okay, lactobacillus they ferment the carbohydrates and result in production of lactic acid, which is responsible for causing caries. The mere production of lactic acid is not responsible for causing caries because the lactic acid produced is like of insignificant amount. The other acids also help in causation of caries. Then the oral actinomyces. Oral actinomyces is nothing but a gram-positive filamentous organism. Mostly it is an anaerobic or a facultative anaerobe. Again, it is of two types like Actinobacillus neslendi, Actinobacillus viscus. Actinomyces neslendi and viscus are facultative anaerobes, whereas Actinomyces israeli and odontolithecus are strict anaerobes. Actinomyces are usually they are their growth is favorable in anaerobic conditions, which is in oral cavity is provided by the root surfaces. So the oral actinomyces are predominantly seen on the root surfaces of the teeth. These root surfaces are usually covered by plaque, the subgingival plaque as such. So Veillonella is another oral microorganism which has been isolated from the plaque lesions and all. But Veillonella, recently authors have attributed that Veillonella has a anti-cariogenic property. So that is like it is preventing from caries and not causing caries. So much has to be investigated about it. Then according to Miller, now that the carbohydrate substrate is present and the oral microorganisms are present, both of these lead to acid production. Fermentation of carbohydrates also lead to acid production, whereas the bacteria, they also metabolize the substrates and lead to acid production. And few of the bacteria, if they may also cause the degradation of protein of the enamel, organic component of the enamel. They also lead to acid production and spread the caries. So the role of acids exactly is not clear. Actually, the acids are produced either by the bacteria or by the carbohydrate. The mere presence of acid doesn't cause the caries. The acid should be localized on the surfaces of teeth. So how they are localized on the surfaces of teeth is the next question. So then comes the role of dental plaque. Plaque will study. So the acids which are responsible for causing caries are chiefly the lactic acid and the butyric acid. So the microorganisms ferment the carbohydrates to produce acids. Chiefly it is the lactic acid, and other inorganic acids are also like butyric acid, propionic acid are also produced. Acid formation is slower upon application of cooked starches. So this acid has to be localized on the surface of the tooth. So then came the clinical picture of the presence of dental plaque. Dental plaque, it is of vital significance both in the initiation as well as in the progression of dental caries. Actually, Miller thought that the dental plaque acts as a preventive mechanism. It prevented the causation of caries. It is like a protective factor according to Miller. But later on it has been shown that the plaque is the inhabitant of microorganisms. The carbohydrates are localized on the surface of the tooth by the presence of plaque. So it is also responsible for decalcification of enamel and causing caries. Plaque is nothing but soft, translucent, tenaciously adherent material on the surface of the tooth. Plaque consists of salivary mucin, epithelial components and bacteria. 90% of plaque consists of the bacteria and its byproducts. Plaque, actually the microorganisms initially they attach to the acquired pellicle, then through specific adhesive and cohesive interactions, more of the microorganisms are attracted towards the surface of the tooth. Acquired pellicle is nothing but a soft biofilm formed on the surface of the tooth in the lack of mechanical cleansing, or immediately after cleansing within 24 hours the acquired pellicle forms. It is basically a base for attraction of carbohydrates, foods as well as bacteria. So plaque is actually classified as supragingival and subgingival plaque based on the presence. Supragingival is which is present above the level of gingiva, and subgingival is which is present below the level of gingiva. Subgingival plaque mostly leads to disturbance in the supporting periodontal structures. More of periodontal diseases are caused because of this subgingival plaque. Whereas supragingival plaque, it is seen on the cervical surfaces of the teeth, cervical, buccal or lingual surface of the teeth. They form as a base for the attraction of carbohydrate substrate. So they are responsible for decalcification of enamel in that region. So bacteria initially they attach to the acquired pellicle, then the bacteria, more of the bacteria are attracted through adhesive interactions. Dental plaque is permeable to carbohydrates. So the plaque material, the foods are lodged on the surface of the teeth. So the carbohydrate, whatever is present, it has become retentive on the surfaces of the teeth because of the plaque. These plaque, they degrade the carbohydrate and release the substrate onto the teeth. So this this biofilm, whatever the dental plaque biofilm is there, it is permeable. It permits the movement of carbohydrates through from oral cavity onto the enamel surface. But later on, Stefan showed that the carbohydrates are once the carbohydrate is attracted on the surface of the tooth, after few hours like that, it is degraded. It is not present throughout in the dental plaque. Once it is attracted on the surface of the tooth and it is permeable and it is permitted onto the enamel surface, then it is degraded. It has to be continuously replaced on the enamel surface through our oral intake. Whenever we take the glucose solution or there is intake of starches, the plaque, the glucose is deposited on enamel plaque surface. Then it is transferred onto enamel surface. Suppose the intake has been stopped, then the carbohydrates are not available in the plaque. This Stefan has demonstrated with the help of a Stefan curve. He showed that pH of plaque after rinsing the mouth with a solution of 10% glucose. So initially the plaque pH was about 7.1% in caries free persons and about 5.5% in persons with extreme caries activity. After rinsing the mouth with 10% glucose, within 2 to 5 minutes, the pH falls to 4.5 to 5. Within 2 to 5 minutes after rinse, pH falls to 4.5 to 5. Then it gradually returns to the initial pH level of 1 to 2 hours. So this is the Stefan's curve, which shows the rise and fall in pH as the glucose intake is taken. So we have seen that according to Miller, role of the microorganisms, role of the carbohydrate substrate, role of acids, and even the role of dental plaque. So that's with the Miller's theory. Now there have been other theories which stated that apart from the acid localization and the microorganisms, there is breakdown of organic components of enamel. Breakdown of organic components of enamel. This is the basis of this proteolytic theory. According to proteolytic theory, organic or protein elements are the initial pathways for invasion of microorganisms. Bodecker has proposed that the organic components of enamel are nothing but the enamel lamellae and the enamel rod sheets. So this enamel lamellae served as a pathway for entry of microorganisms. Then there was Gottlieb and Baum, who also stated that initially there is proteolysis or the breakdown of organic portion of enamel. Then there is presence of microorganisms also in the enamel lamellae. Both of these lead to acid production by the microorganisms and the breakdown. Both of these lead to decalcification or destruction of enamel. It has been held that the yellow pigmentation seen is due to the caries, and this pigment is produced by the proteolytic organisms. Actually, Miller's theory was it is the backbone of etiology of dental caries. It is widely accepted, but all the evidences of Miller's theory are just circumstantial, and histologically we have seen that there is a proteolysis. So this theory has been proposed, proteolytic theory. So according to the proteolytic theory, the drawback of proteolytic theory is that no support evidence was there to support that the initial attack is the proteolysis or the breakdown of enamel is the initial attack. Then the gnottobiotic studies were conducted, which indicated that caries can occur even in absence of some few of the proteolytic microorganisms. Then proteolysis may not be involved in initiation of caries, but it is definitely involved in the progression of caries. So the initiation may be because of the acids or because of the microorganisms. But the progression, that is the breakdown of enamel by bacteria, it is definitely indication of a progression of Caries process. Then another theory have been proposed, that is the proteolysis chelation theory. It has been proposed by Schatz et al. According to this, simultaneous microbial degradation of organic components, that is the proteolysis, and the dissolution of mineral components of teeth through chelation, both of these takes place simultaneously. So chelation process is nothing but the complexing of a inorganic metal ion to another metal through coordinate covalent bond. Through coordinate covalent bond is formation is seen as in cases of hemoglobin. Okay, so this leads this coordinate covalent bond formation or the chelation process is the end product is a weakly dissociated compound which is just soluble, which is dissociated. So according to this proteolysis chelation theory, initial attack is on the enamel, which is the proteolysis. It leads to the breakdown of products. These are dissolved, enamel is dissolved because of the chelation. Then soluble chelates are formed. There is a weakly dissociated compounds are formed with the mineralized component of the tooth. Thereby these dissociated compounds are further broken down and they decalcify the enamel even at alkaline pH. Then there was sucrose chelation theory was proposed. According to sucrose chelation theory, sucrose itself is not responsible. Sucrose itself can cause the disease rather than the acid formed by it. So Egler-Slora proposed that theory. Sucrose as a substrate itself can cause the dissolution of enamel surface and not the acid produced because of it. Usually it has been stated that the acid is responsible for causing dissolution, but sucrose chelation theory states that the substrate sucrose itself is responsible for causing dissolution of enamel. It is because of the chelation process. It results in formation of calcium saccharate. Okay, this calcium saccharate and the other calcium complexing intermediaries, they require inorganic phosphate for their acid production, which is subsequently removed by enamel by phosphorylating enzymes. So here sucrose is the causative agent for causing caries. Then there is other theory called the autoimmune theory. According to this theory, it states that few odontoblast cells are damaged in some specific sites near the pulp on few of the specific teeth. In some teeth, what happened? Few of the odontoblast cells are damaged near the pulp. Wherever there is damage of odontoblast cells, the overlying enamel and dentine are also damaged. They are compromised and they show the development of caries. So now we will study the current concepts in caries etiology. Whatever we have studied previously are the theories that have been seen through history or through evolution from 16th, 17th, 18th, 19th century to the present 21st century. So now the current concept is the Keys circle or triad of etiology of dental caries. It has been proposed by Keys, so it is called the Keys circle. Okay. Initially, three primary factors were attributed for causing caries, that is the host, tooth surface, then the microbial flora, all the oral microorganisms, then the substrate, that is the carbohydrate. Then the recently fourth substrate has been added, that is the time. The time period for which the carbohydrates are present in oral cavity also influence the caries process. So this is the Keys circle. We can see host is the tooth surface. The factors which influence the host are the age of the person, the fluoride, the genetic, the hereditary process. Caries immune individuals, the siblings are caries free. Caries affected individuals, the siblings are caries, show presence of caries. Then the microbial flora, presence of fluoride in plaque, they also have an inhibitory effect on the growth of microorganisms. Then lactobacilli, oral hygiene procedures, when excellent oral hygiene procedures are followed, then the growth of microorganisms is less. Then saliva shows the factors which affect the presence of saliva is the pH, flow rate, composition, buffering capacity and bicarbonate level. We are going to study this in detail. Then substrate, the frequency of ingestion, the physical form, composition, etc. So the factors that influence the caries etiology, the host, the microorganisms and the tooth. First is the tooth, the composition of the tooth, saliva, diet and systemic conditions we are going to study now. So how is the tooth surface affected by presence of caries? So the factors which influence the caries etiology, the tooth, the composition of the tooth, the morphologic variation of the tooth or the presence of the tooth at the site in oral cavity all affect the development of caries. Like suppose if we consider the composition of the tooth, Broodwell and his associates in their studies have shown that the surface enamel is intact, but the subsurface enamel may show demineralization or decalcification. The surface enamel is relatively intact because it has been bathed by the saliva and there is incorporation of minerals or fluorides, phosphate ions from the oral cavity. So even though the surface is intact, the subsurface enamel may show demineralization. Then coming to morphology, the presence of deep fissures, deep pits, deep fissures in the occlusal surface of premolars, molars or the lingual pits of the maxillary incisors and all, they all show, they are the sites for retention of foods. So bacteria and food debris become stagnated in these areas and they are more prone to develop caries and such. So if suppose the teeth are like malaligned or out of position or rotated, they also tend to favor the accumulation of debris and in turn leading to caries. The teeth have been constantly bathed by saliva. Saliva actually it is thought to have a lot of mechanisms which hinder the development of caries. Lot have been talked about the buffering capacity of saliva. Saliva is composed of both the organic components and the inorganic components. The calcium phosphate concentration in saliva actually it acts as a defense mechanism. The enamel surface, the hydroxyapatite crystals, they also have the calcium and phosphate. And the saliva, when it is supersaturated, in its supersaturated state, it prevents the dissolution of minerals from the enamel surface. So in case when there is fall in pH levels, in such cases this supersaturation is lost and the calcium and phosphate are dissolved from the surface of enamel. And saliva also shows presence of a variety of enzymes like amylase or ptyalin, which are responsible for the fermentation of starches, in turn leading to acid production. Saliva of pH of saliva. The pH at which any particular saliva ceases to be saturated with calcium and phosphate is referred to as critical pH. Usually it is about pH. Usually this pH is about 5.5. Below this value, if the pH falls below 5.5, the inorganic material of tooth may dissolve. The acid production during caries occurs at localized site on the tooth. The dental plaque, it acts as an osmotic membrane. It prevents or it doesn't permit the free exchange of ions. It is a selective membrane, it is an osmotic membrane, it permits the exchange of only few of the ions. So dental plaque also acts as a, it also prevents the caries even though the pH has fallen down. Saliva has presence of this bicarbonate buffer system. The bicarbonates in saliva usually exist in the forms of like dissolved carbon dioxide or bicarbonate forms. When the saliva is exposed to oral cavity, there is the loss of dissolved carbon dioxide. So the bicarbonate ions are like lost. So the bicarbonate system acts as a buffering system for saliva. So the saliva shows presence of the bicarbonate buffer system. The bicarbonate in saliva, it exists in the form of dissolved carbon dioxide and the carbon dioxide. Whenever the saliva is exposed to air, there is loss of dissolved carbon dioxide. Then this dissolved carbon dioxide, there is further loss of bicarbonate ions from oral cavity due to the presence of enzyme carbonic anhydrase. These bicarbonates, when there is loss of pH, when there is fall of pH also, these bicarbonates, they permit diffusion through the plaque onto the enamel surface. Thus thereby this bicarbonate buffer system also helps. The quantity of saliva. Caries incidence is higher when there is reduction of saliva, when the saliva is reduced. As in cases of xerostomia, the oral cavity, the saliva, it has lot of buffer systems, right? When there is reduced salivary flow, there is increase in caries incidence. It may be seen in cases of hypoplasia of salivary gland aplasia. Continuous flow of saliva helps in mechanical removal of retentive food or bacteria from the oral cavity. Viscosity of saliva. Viscosity of saliva has not been attributed to caries causation because there is no link. Even when the saliva is thick and mucinous, there have been reported caries, very few caries incidents. Even when the saliva is thin or watery, there have been increased caries incidences. So there is no direct link. Actually, the viscosity of saliva is attributed to the mucin content of the saliva. The mucin content is derived from the submandibular, submaxillary and the sublingual glands. So according to Miller, viscosity was not of great importance. Then the antibacterial property. Saliva has a lot of antibacterial factors like the peroxidase systems, the immunoglobulins, the lysozyme enzyme, the lactoferrin. Immunoglobulins IgA and IgM, secretory IgA and secretory IgM, which are different from the serum IgA and IgM. These have been, they acted as the protective factors. Bibi pointed that their efficacy has been doubtful. Though salivary immunoglobulins are like caries protective, they help in protecting from caries. They have been, Bibi, an author, has attributed that even though immunoglobulins are present, saliva has presence of such other organisms, such other microorganisms, that it definitely causes caries if carbohydrate substrate is present. Other contributing factors of which affects the etiology of dental caries are the physical form of the diet. Physical form of the diet, we have already discussed that sticky carbohydrates are more caries producing. Then carbohydrates which are not easily cleared from oral cavity are also more caries producing. Initially the diet of the primitive man, it consists of much of roughage, so the teeth were mechanically cleansable, but now the industrialized diet, soft diet, so these refined pure carbohydrates are more cariogenic. Then the carbohydrate content of the diet, sucrose is essentially considered a very important, substrate for causation of caries. So sucrose is more cariogenic than other. Then many studies were conducted, like epidemiologic studies were conducted to attribute which carbohydrate is more cariogenic or how the carbohydrate is more cariogenic. One such study was the Weibholm study. In this institution, all persons were caries free initially. So then during the study, they were divided into 7 groups, and sugar was introduced in their diet. Sugar was introduced at different times, in between meals or after the meals, along with the meals. So they were divided into 7 groups. So when finally the results were seen, the results were that increase in caries incidences were seen along with increased carbohydrate consumption, and in between meals, if sugar was taken, then there was much increase in caries. and if the sugar was like withdrawn from the diet after a few months, then there was automatically the reduction in incidences of new caries lesions. Lipid content of the diet. Lipid content is nothing but the medium chain fatty acids and their salts. They have shown antibacterial effects. The mechanism of these is not well defined. Actually, there may be changes in cell permeability when medium chain fatty acids were introduced. The experimental studies were conducted with the help of potassium nanoate. Potassium nanoate is nothing but a medium chain fatty acids. It was introduced in oral mouth rinses. So whenever the person rinsed his mouth with potassium nanoate, there was significant reduction in caries incidences. Much have to be studied or to be investigated in this field. Then the fluorine content. Whenever fluorine was taken, whenever fluoride tablets were taken, there was some, even if they are metabolized, the availability, the bioavailability was a little bit reduced. When topical and systemic fluorides were introduced, they caused a reduction in caries incidences. Vitamin content of the diet. Vitamin D and vitamin K both have been attributed to role in caries process. Vitamin A deficiency was also initially attributed because they affect the epithelial cells, but it has to be investigated. Like vitamin D, it affects the calcium formation of the teeth. So deficiency of vitamin D leads to defect in formation of the teeth or the structure of the teeth. It results in enamel hypoplasia. So vitamin K, it has thought to be having anti-cariogenic effect because of its enzyme inhibition action. Vitamin K is suggested as an anti-cariogenic agent. Other systemic factors which are implicated in caries role are the heredity. We have already seen in the previously that parents, if they have caries, then the children tend to acquire caries at a higher level. Then siblings of caries immune individuals are relatively caries free. So even though heredity actually gives the form of the tooth or the structure of the tooth, but the possibility of causing caries depends on local factors, especially the diet. Heredity has a role, but it has been modified by the local factors. Pregnancy and lactation, the increased caries incidences during pregnancy and lactation are supposed to be a problem of neglect. Actually, few of the authors gave an opinion that during pregnancy there are less chances of caries, but because of other problems like taking care of the newborn and all, actually caries incidences were increased. So now we are going to the topic classification of dental caries. So as we have seen, the dental caries is a dynamic process. It is almost a universally accepted disease now. So we'll see it is classified based on a number of factors, based on the anatomical side, based on the rate of caries progression, based on the nature of attack, based on the number of surfaces involved, based on the virginity, based on whether the attack is the initial attack or recurrent attack, based on the tissue involvement, based on the spread of caries, and the universally accepted Black's classification. So we are going to study them in detail now. So based on the anatomical site, based on where the dental caries is located on the surface of the tooth, it is divided into pit and fissure, smooth surface caries, linear enamel caries and root caries. What are pits and fissure? Pits and fissures are nothing but developmental defects or faults. Okay, pits and fissures are seen on the occlusal surfaces of molars and premolars. Pits are seen on the lingual surfaces of maxillary incisors. They represent the developmental defects or the developmental anomalies. Okay, these pits and fissures, they favor the retention of food. The pits and fissures, they are not mechanically cleansable, self-cleansable, Okay, they favor the retention of food. These food carbohydrates, they undergo fermentation and leads to acid production. Then acid production leads to demineralization of enamel. So clinically they appear as brown or black, blackish deposits on the pits and fissures. Initially they may not be detectable by the sharp point of the explorer when just the beginning of the enamel caries lesion. It is just appears as a white spot like a thing. Then later on, as the caries process progresses, the enamel prisms undergo dissolution, there is discontinuity of the enamel surface, and then you get a catch with the explorer point. Pits usually they have steep bases, okay, steep walls. Pits are usually have steep walls and they have narrow bases. Sometimes the enamel will be reduced to such an extent, enamel will be very thin at the bases of pits, at such an extent that initially the caries progresses from the pit and it spreads laterally along the dentino-enamel junction. So it involves greater number of dentinal tubules. To look from outside, there will be a narrow penetration point, there will be a small point of entry, but underneath this enamel, the enamel is undermined, underneath this enamel there is the spread of caries will be to a much greater extent in the dentine. So we can say that this pit and fissure caries is masked, it's undermined because the enamel is undermined. So once if the pit is open, like there is a lot of dentinal tubule involvement may be seen. So here in the clinical picture you can see that the pit and fissure caries extension is a cone shape, it is a triangular shape. If you see only the enamel part, okay, it is triangular shape, narrow point of penetration is there, initial point is narrow, again it spreads laterally along the DEJ, it is a cone shape with the apex at the pit and the base towards the dentino-enamel junction. Smooth surface caries. Smooth surface caries are usually seen on the any surface of the tooth, either the buccal surface, lingual surface or the proximal surfaces of the tooth. Usually smooth surface caries are preceded by the formation of plaque. Pit and fissure caries are basically the food retention. Here in the smooth surface caries, because the surface is smooth and mechanically cleansable, dental plaque helps in the retention of carbohydrates on the surface of the tooth. So plaque formation will be there. Buccal, lingual or the gingival thirds of the surface of teeth show presence of smooth surface caries. The area usually appears as yellow or brown pigmented area clinically. Here the spread of caries is that initially only it involves a greater surface area. So the open cavity is seen, but the area of penetration, as the layers of enamel are involved, the point of penetration it is a cone shaped, but initial point of entry is large and the area of penetration is like narrow. If we can see the clinical picture here, so the proximal surface of the teeth is showing smooth surface caries with involvement of greater surface area initially, then the decalcification proceeds inside, but the point of penetration is like narrow, it has narrowed down. Initially it is wide, then it has narrowed down. Then there is something called linear enamel caries. It is particularly seen in isolated like racial Asian population. It is seen on the labial surface of anterior maxillary teeth. Usually linear enamel caries is seen in the region of neonatal line. Neonatal line is formed because of area of trauma or hypocalcemia during birth. So it results because of a metabolic disturbance. So linear enamel caries in an isolated population is referred to as odontoclasia. Then based on the location, if caries is usually seen in the cervical third of the teeth, it is referred to as cervical caries. Usually they may be seen on the buccal, lingual or labial surfaces of the teeth. Cervical caries usually occur, mainly the etiology is the lack of oral hygiene. Okay, it begins as a crescent shaped cavity. That initial cavitation is a wide or shallow one, then it progresses, the dentin becomes softer as it progresses. As enamel and dentin is involved, the dentin becomes softened and the lesion becomes arrested. There will be softening of dentin. Initial rough and chalky area is seen, slightly rough and chalky area is seen, and later on cavitation is seen. So here in the clinical picture you can see the teeth showing cervical caries, usually attributed to poor oral hygiene. Root caries, it is defined by Hazen as a soft progressive lesion occur on the surface of the teeth that have lost clinical attachment, most commonly seen on the root surfaces. So root caries is usually seen in older individuals or older age persons which show recession of the gingiva or the root surfaces is exposed. The oral microorganism which is responsible for root caries is nothing but the oral actinomyces, that is Actinomyces viscus predominates on the root surfaces because of the anaerobic environment there. So the microorganisms, they invade between the Sharpie's fibers. Actually the cementum, it shows presence of concentric lamellated fibers. So there is lateral spread of caries here. Then the decalcification of cementum occurs, then there is the destruction of matrix, then it involves the dentinal tubules, and finally it reaches the pulp. The destruction and decalcification of dentin also occurs. Based on the location is done. Now based on the rate of progression, whether it is developed in a short period of time or whether it's developed it's taking longer time to develop, it is divided as acute, chronic or arrested. So what is acute caries? Acute is nothing but of short period. So acute dental caries, it runs a rapid clinical course. Usually the involved teeth show multiple pulp exposures. So as soon as the caries process begins, there is involvement of pulp with multiple pulpal exposures. It is usually seen in the younger individuals, okay, children and in young adults. Because what happens is in children, the dentinal tubules are relatively larger in size. So there are less chances of sclerosis, okay, because the dentinal tubules are larger, the caries process progresses very rapidly. So the secondary dentin deposition does not take place. So there are no signs of sclerosis because all the pulps are involved. The pain is a characteristic feature of acute dental caries. Clinically, the dentin appears light yellow in color. Acute dental caries, actually the point of penetration is usually a smaller one, but it progresses largely in the dentinal tubules because of their wider dentinal tubules. So the initial point of penetration is like very small and it progresses widely. Another point is that because the point of penetration is small, the saliva, though it has the buffering capacity, it is not able to reach the microorganisms. It doesn't buffer the carbohydrate substrate, etc. So saliva has little effect on acute dental caries. Then the other one is the rampant dental caries. Rampant dental caries is nothing but it is characterized by sudden involvement of a sudden and uncontrollable destruction of teeth. Okay. It also runs a very rapid clinical course. Rampant caries is usually seen in the middle-aged individuals or the older individuals. Rampant caries usually affects the surfaces of the teeth that are relatively immune to caries, usually the mandibular central incisors. proximal and cervical surfaces of mandibular central incisors. Usually they are bathed continuously by saliva and they are thought to be as caries free, but rampant caries affects those teeth also. Rampant caries is seen in primary dentition and in teenagers. There is complete destruction of enamel and dentin. Okay, we'll study rampant caries in children in detail in the next topic. Based on the nature of progression, we'll study chronic caries. Chronic caries is nothing but caries which progresses very slowly. It is usually seen in older individuals or adults. Here what happens is because of age factor, there is the dentinal tubules are little bit smaller in size when compared to children. So there are sclerosis of dentinal tubule occurs and there is deposition of secondary dentin. So as soon as the decalcification occurs, so dentin shows formation of secondary dentin. Here the entrance to the caries is larger. Okay, shallow open cavity is seen. So as the open cavity is there is lack of food retention. So food is not retentive there, and the saliva helps in cleansing of the surface of the teeth. So buffering capacity of saliva helps in neutralization of acid. So this disease progresses a little bit slowly. Pain is not a common feature of chronic caries. Acute caries develops within a short period of time, so pain is seen. But chronic caries like progresses slowly, so pain is not a common feature. Another caries is the arrested caries. Arrested caries is nothing but caries which has started, but because of few local factors, the caries process is arrested or it has become static. The surface of the enamel or dentin, it has hardened. Usually large open cavities in the caries process has started. It involves few layers of enamel dentin, but the dentin becomes softened. Clinically these appears as brown in color, deep stained brown in color. So the superficially softened dentin, it is gradually hardened, or something called as hibernation of dentin. Softened dentin, it becomes hard or shiny in nature. So secondary dentin formation actually helps in arresting this caries process. Once the caries has started, but the buffering system of saliva is there and there is lack of food retention, and suppose the patient has started taking care of his oral cavity by instituting some fluoride in his mouthwashes, fluoride rinses, etc. So the caries process automatically stops. Remineralization occurs, we can tell. So based on the nature of attack, whether the caries first time the tooth is affected by some process, some caries process, that is the primary caries. Secondary caries is previously the caries was present, it was treated, and then beneath that carious lesion, beneath the treated lesion only another the caries process has progressed. So that is called as secondary caries. So it's also nothing but virginity, whether it is noticed first time or like recurrent, initial or primary, recurrent or secondary. Primary caries is nothing but a lesion, initial attack on the tooth surface, lesion which is the initial attack on the tooth surface. The designation of primary is based on the location. Suppose the occlusal surface of the teeth is affected for the first time, that is the initial caries. Recurrent caries is nothing but caries which was treated for once and again it has recurred in the same place. Most commonly recurrent caries is seen in places in association with restorations. Suppose the tooth has been restored but the restoration was not extended up to the gingival margins, or there was inadequate extension, or there was leakage of the materials. If you can see the clinical radiological picture, so beneath the restoration the caries has progressed. It is due to poor adaptation of restoration to the gingival margin, leading to leakage and localization of acids on the surface of the tooth. Food retention also occurs in proximal caries. So proximal caries most commonly show recurrence. So based on chronology, at what age they have been seen? Okay, either in childhood, early childhood stages, or in adolescent or adult caries. Okay, early childhood caries is nothing but again it is of two types, rampant caries and the nursing bottle caries. So the difference between nursing bottle caries and rampant caries. The rampant caries involves mandibular incisors. Mandibular incisors are usually the teeth which are regarded as being caries free in oral cavity, because they are continuous flow of saliva is there, lesser retention of foods on mandibular incisors. But rampant caries is a uncontrollable destruction of teeth which involves even the mandibular incisors, and nursing caries doesn't involve the mandibular incisors. The etiology of these two caries is also different. Nursing bottle caries is called by other names as bottle propping caries, comforter caries, baby bottle mouth, nursing mouth decay, or baby bottle tooth decay. Another newly given name is the maternally derived streptococcal mutant syndrome. So, nursing bottle caries is usually seen in infants, but rampant caries is seen at all ages. Okay. The etiology of nursing bottle caries is improper bottle feeding or usage of a pacifier like honey dip pacifier in between meal times. If any pacifier or mixed with any sweetener is placed in the oral cavity of infant, then it gives rise to nursing caries. Whereas rampant caries is because of the nature of intake of diet, that is the frequency of ingestion, the physical form, the nature of diet taken, and the presence of other systemic or local factors like decreased salivary flow, xerostomia, etc. So main difference between nursing bottle and the rampant caries is the involvement of mandibular incisor teeth in rampant caries. Usually in nursing caries, the maxillary 4 incisors are affected, followed by molars, maxillary molars, and then sometimes even the cuspid. Usually all of the teeth show gross destruction such that only the stump of root may be seen from the gingiva. Both enamel, dentine is affected, and complete crown is lost actually. Adolescent caries is nothing but a variant of rampant caries. It is seen generally in the teeth which are involved, which are considered to be immune to decay. This type of caries is usually a rapidly burrowing type with a small enamel opening. That is, it's like as we see in pit and fissure caries. The point of entry is very small. Beneath that, the dentinal tubule, there is lateral spread of caries process at the dentino-enamel junction, and the involvement of pulp. Early pulpal involvement is seen in adolescent caries. Adolescent caries usually seen in the chronological age group of 11 to 18 years of age. At this age, because of diet, basically this caries process progresses very rapidly, and involvement of teeth is also very rapid. So because at 11 to 18 years, if there is gross destruction of teeth, you'll have lot of problems in mastication or eating. So treatment should be instituted. Treatment and diagnosis earlier should be done. Then adult caries are nothing but seen in the older age groups. In the older age groups, what happens is usually the periodontal structures are weakened, so there will be recession of gingiva. So the caries is usually seen in the cervical third of the teeth. Because of lack of oral hygiene also, there is a cause. Then decreased salivary function or xerostomia also leads to increased caries development in cases of adults. Based on the extent of caries, so how is the caries, whether the caries is has just started or it has progressed to some condition, based on that classification it is divided into incipient, occult and cavitation. Incipient caries are nothing but the early carious lesions seen in the enamel surface of the tooth. They are usually seen as a white spot on the surface of the tooth. Many authors have suggested that the surface of the tooth is relatively resistant to demineralization, but the subsurface shows a greater amount of demineralization. The surface is usually it has exposed to oral cavity, calcium and phosphate intake is there, so it will be relatively harder in color. Initial change noticed is the opaque chalky white area. Occult caries are nothing but hidden caries. If we see fluoride exposure cases, or in cases where there is intake of fluoride in some form, either in mouth rinses or in toothpaste, the caries, initially the enamel shows presence of caries, but as soon as the fluoride is incorporated, the surface layers hardens. Okay, it becomes remineralized and hardened and it is back to normal stages. But the caries process, because it started before the already demineralization has occurred, that part it has not changed. So caries begins beneath the remineralized surface areas. So it appears that the lesion has become marked by a relatively intact enamel surface. Clinically, you cannot diagnose this occult caries. It is diagnosed in radiographs only. Usually associated with fluoride intake. That's why it's called as a fluoride bomb syndrome. Cavitation is nothing but involvement as seen in cervical caries. Okay, cervical caries, how it begins? It begins as a large cavity itself. Okay, enamel is involved, the layers of dentin are involved, and it is a crescent shaped cavity. So once enamel and dentin are involved, the lesion it may involve the pulp also. But there is no definite shape of extension of caries like cone shape. So cavitation is usually seen in cervical caries, as instances of the large open cavity will be seen. There will be lack of food retention and it will be continuously bathed by saliva. So the caries process will be arrested there. So the demineralization has occurred to such an extent in the cavitation that they cannot be remineralized, they have to be treated. So based on tissue involvement, the caries has been classified into initial or superficial, deep or moderate, deep and moderate. Initial caries is nothing but the early enamel caries. It involves the surface of the enamel, demineralization takes place. This stage can be reversed just by fluoridation of oral cavity, fluoride rinses. Superficial caries is also known as caries superficialis. Here pinpoint pit and fissure caries or wedge shaped defects are seen, enamel caries. So caries has affected the enamel layer and it has not yet started penetration into dentin. So caries has reached up to the dentino-enamel junction. That stage is called as the superficial caries. Moderate caries, also known as caries media. Here both the enamel caries and the dentinal caries is seen. Okay, caries has penetrated up to dentin through spread at dentino-enamel junction. Deep caries is nothing but caries profunda or deep structural defect. Here the caries has involved the pulp, close to the pulp. Enamel caries, dentinal caries, and it has just begin penetration into the pulp. Deep complicated caries is nothing but caries profunda complicata. Caries process has started in the enamel, involved the dentin and the pulp. So pulpal pathology may be seen, like periapical infections have started. Based on the pathway of spread of caries, dental caries is classified into forward decay or backward decay. Forward backward classification is based on the graphical representation of pathway of dental caries. We'll see how the dental caries spreads in the enamel and in the dentin. So if we consider the caries process in enamel, initially the caries process involves the interprismatic enamel substance. There is increase in distance, interrod distance of enamel. Then disintegrating substances, they cause the undermining of the enamel prism. Here the caries in enamel is usually a cone shaped lesion with the in concave surfaces, that is in pit and fissure caries. The caries of enamel is a cone shape with the apex at the base of pit and the base at the DEJ, apex at the pit and base at the DEJ. Whereas in convex surfaces, that is the smooth surface caries, the base is away from the DEJ. Both are triangular shaped cavities only, cone shaped defects. So when the caries cone in enamel is larger or at least the same side in dentin, it is referred to as forward caries. If we consider the caries process in the enamel, protoplasmic extensions of the dentinal tubules are involved first. The tubules become densely arranged with fewer interconnections, the tubules become packed closer. Then the caries cone in dentin will have their base towards the DEJ. Decay starts in the enamel first, then it involves the dentin. Here also the caries process is like a cone shaped lesion, but it starts with initially with the lateral spread at DEJ. So the base is towards the DEJ and the apex is towards the pulp. So the caries process in dentin progresses much faster because of involvement of greater number of dentinal tubules. The decay can attack from dentinal side or from the enamel caries. So it has been referred to as the backward decay. Based on the number of tooth surface involved, dental caries is classified into simple, compound, complex. Simple is nothing but a single tooth surface is involved. Compound is one or two surfaces of tooth are involved, like the buccal and the lingual, both are involved. Simple is nothing but only the occlusal surface is involved. Complex is the involvement of surfaces of more than two surfaces of the teeth, or a deep complicated caries it can be called. Black's classification of dental caries is universally accepted. According to Black's classification, class 1 includes the occlusal surface of pits and fissures of molars and premolars. Usually class 1 caries occurs in the regions of structural defects, that is the pits and fissures. Buccal and lingual surface of premolars and molars, the occlusal surfaces and the lingual surfaces of anterior 2. Class 2 include the proximal surface of premolar and molars, that is the proximal caries. Class 2 is nothing but the proximal caries. Class 3 are the lesions found on anterior teeth without involving the incisal angle. Class 4 are the lesions involved on anterior teeth with involvement of incisal angle. Class 5 are nothing but seen on the gingival third of the facial or lingual surface of anterior or posterior teeth. Class 6 is lesions involving the cuspal tips. So you can see a picture there with class 1, class 2, class 3. Class 4 is involving the anterior teeth with the incisal edges. Class 5 is exclusively seen on the gingival thirds. Class 6 involves the cuspal tips. Radiation caries. Radiation caries is nothing but few of the individuals they undergo radiotherapy of head and neck region in association with some tumors or treatment of some cancers and all. So they show development of caries called radiation caries. So this radiation therapy or radiotherapy, it is associated with decreased salivary function. Radiography of radiotherapy of head and neck region is usually associated with decreased salivary function or xerostomia, fall in pH, decrease in viscosity. All these lead to increased caries incidences. Radiation caries is usually a rampant form of caries. Three types of radiation caries is noticed. The first one is usually seen, based on clinical appearance, it usually appears as a caries encircling the crown of the tooth, usually seen in the cervical third of the root, the cervical third of the crown. The crown is totally, completely destroyed. It appears as amputated crown. So it involves the buccal, lingual and the cervical surfaces of teeth. Second form is the brown to black discoloration of teeth, which is usually involving the occlusal surfaces and incisal surfaces of teeth. A third type of radiation caries is nothing but a spot depression which spreads away from the surface of teeth, usually seen in the buccal, lingual, occlusal surface. Involves all the surface of the teeth. Spot depression involves all the surface. So the another caries process, enamel caries remineralization. Enamel caries remineralization. What happens is, it is usually observed by many authors that the caries process, when the caries process has started, initially it appears as a white spot, right? Anderson in 1938, he saw that when the white spot was exposed to certain conditions like incorporation of fluoride in oral mouth rinses, incorporation of fluoride mouth rinses, the enamel surface hardened. Okay. Then in Mueller, author Mueller in 1961 also showed that topical application of stannous fluoride leads to remineralization of enamel process, that is the enamel surface is hardened. Then based on investigations by various authors, it was proved that exposure of softened tooth to calcium phosphate solution leads to hardening of enamel. This hardening of enamel was further accelerated when 1 ppm of fluoride was also incorporated into the solution. Based on these experiments were conducted by Silverstone in 1970s. Okay. Thus, these all experiments showed that some natural biologic remineralization process exists in the mouth, and it has been showed that fluoride greatly increases the rate of absorption of calcium phosphate. The fluoride itself sometimes become incorporated into the enamel, thereby leading to hardening of enamel structure, that is the remineralization of enamel. So here the surface layer may be intact, but the subsurface may show caries. Still the caries may be continued. Because the surface is exposed to oral cavity or saliva, where there are a lot of calcium and phosphate ions exchange, the surface was hardened. But beneath the surface, the subsurface layer, the caries process continues. So histopathology, let us study the ground sections of demineralized teeth to know how the caries process is going on. Usually histopathology of dental caries is examined in ground sections of teeth by taking ground sections of about 10 micrometers to 100 micrometers. They are observed in scanning electron microscope and transmission electron microscope. So first we'll see the caries process, how it is going on in enamel, how it is going on in dentin. So first we'll study the enamel caries process. In the enamel caries process occurs through beginning, if it is pit and fissure caries. Suppose if it is pit and fissure caries, it's like a cone shaped lesion beginning from the pit, spreading from the lateral sides of the pits. The pits are usually in shapes of like Y shape or funnel shapes or hourglass shape. Okay, both from the lateral side of pits, the caries process starts and it reaches the dentino-enamel junction, then the lateral spread of caries occurs. Suppose the smooth surface also has a caries process which begins on the surface of the tooth. Initially it involves a wider area, but later on the point of penetration becomes narrow towards the dentino-enamel junction. So here we can see the clinical picture showing that the caries process begins from the side walls of fissures. So when the microscopic images were observed for the caries process, enamel caries lesion, 4 different zones were observed. They are the translucent zone, the dark zone, the body of zone and the surface zone. Usually the surface will be unaffected because of the remineralization process. The translucent zone is the zone which is seen farther into the enamel, towards the dentino-enamel junction actually. So if you can see the diagram there, surface zone is the first zone which is unaffected, then is the body of the lesion, then is the dark zone, then is the translucent zone. So translucent zone is towards the dentino-enamel junction. So zones of enamel caries. Translucent zone is nothing but the first recognized zone of alteration. It is seen at the advancing front of the lesion. So the lesion is advancing from the enamel surface to the DEJ, right? So it is seen towards the DEJ. So to study the microscopic images of enamel caries, the ground sections have been studied in a medium which has a refractive index similar to that of enamel, that is the quinolone. Okay, pores are formed, that is the surface, that is the translucent zone. This zone shows appearance of pores, which are like the percentage of pores is 1%. Volume is 1% pore volume compared to that normal enamel. Normal enamel just has 0.1% of pore volume. This pores are attributed to decalcification of enamel, or what happens when the caries process starts, there is loss of interprismatic substance, or the interrod distance between enamel rods increases. So that's in that way the pores are appearing as the lesion is advancing. This is translucent zone is located towards the DEJ. So at that area more pore volume is seen, about 1% pore volume is seen. So and when the so after the translucent zone you have a second zone called the dark zone. This dark zone lies superficial to translucent zone. Here the striae of Retzius are more prominent. There is accentuation of striae of Retzius. It is also referred to as a positive zone. Positive zone means because it is present. Okay. Normal enamel shows negative birefringence when the ground sections are studied in transmission electron microscopy. They show negative birefringence, but the dark zone shows positive birefringence. When the medium imbibed with quinolone is observed, the dark zone it appears like structureless. It has presence of relatively very small pores. The translucent zone has wider pores. The dark zone has small pores. Quinolone it doesn't penetrate because it has larger molecules, but the pore size is smaller in this dark zone. They don't penetrate, so the lesion, so this ground section appears dark in color. Suppose if we substitute the quinolone with another medium like water, so it has smaller molecules, right? So it penetrates and we are not able to see the dark zone. There is no dark zone is visible if medium like water is used. So the body of lesion lies between the unaffected surface layer and the dark zone. The pore volume is about 5% in the periphery and 25% in the center. This body of lesion is the area of greatest demineralization. When observed in transmission electron microscope with quinolone imbibition, this zone appears transparent. Water imbibition, transparent or transparent, like body appears translucent. Water imbibition, when the medium was replaced, quinolone was replaced with water, positive birefringence were observed. Striae of red zeus appears to be more prominent here. Surface zone. Surface zone is a zone which is relatively unaffected, or it shows, initially it shows demineralization about 1 to 10%, pore volume is less than 5%. It has a negative birefringence properties similar to that of normal enamel. It remains intact only because of the remineralization process. Initially it was demineralized, but later on because of remineralization process it becomes hard.